So that's why we say that everybody has TB, but it is so dormant that it does not cause you to have either cough or fevers or what. Now, as you grow up, that original immunity from the vaccine tends to wear away. But you keep that strength of fighting. Now, when your immune system comes down, you tend to get it. It tends to come up. Or if your immune system comes down and you have someone, as Dr. Sophia was saying, that is coughing, and coughing the germ can easily give it to you. And once you get it, then you manifest with the signs and symptoms of the disease. If you manifest with the signs and symptoms of the disease, then actually you begin to show that actually this person has now the real tuberculosis.
Okay. Now, you talked about, okay, yes, Dr. Sophia.
Yes, like Raymond has explained, because the disease is transmitted through the air, and we started from a situation where the disease was widespread. So somehow people get exposed to the disease as they interact with others routinely. So you get, it is estimated that one person with TB in 1 year can infect 10 to 15 other people if they don't get diagnosed and treated. So somehow we get exposed and get the infection in our bodies. But the body is able to control this infection and control it so that it doesn't cause us disease. But anything that shakes our immunity now lets this germ that was under control, under check, flare up, and it brings disease, so you present with the signs and symptoms of disease. Okay. So the estimate really is around that a quarter of the population has the TB germ in their bodies.
Okay. Now, when you talked about the factors, and when we still get back to the statistics of the disease burden in the country, what is the cause for the rise? Because you see, if HIV, if it's taken over and surpassed HIV, it is really worrying. What do you think is the cause of that rise?
So there are a number of causes that are causing the rise. But one is TB, as we said, is an airborne disease. So when you get into a congested population, a population that lives together, then you begin to see this disease manifesting. So we are getting a lot of, inflows from rural into urban places. So that's one. So when you have a big population that lives together, you will tend to see in that particular population, especially in the urban settings, you tend to get a lot of TB cases. And as the population grows, that's what happens. Two, as the saying goes, that once you do not look out and diagnose the disease early, or look out and go and seek treatment early, you tend, as Sophia was saying, you tend to give it to a number of people. So every one person with TB tends to give it to. So that's why we say that if you can go for early diagnosis, if you know you are coughing, go and seek to check for TB. If you don't, the possibilities of transmitting that tuberculosis to many other people, your chances are increased in terms of transmission. Then the other is that we have been hearing about the immune system coming down. HIV, diabetics, and we are beginning to see a lot of people with diabetes, hypertension, and we do think that also that can be an exacerbating factor, especially if your immune system comes down for whatever reason, whether it's HIV, whether it's diabetes, whether it's cancer. And then lastly, and Dr. Sophia can add more, we do think that our poverty is also a very big factor that plays into TB transmission, especially in our homes where we do not have well-ventilated places. And that's where our children are. So if you get TB from, especially us men, if you get TB from the bar or from the community, and you're working in a business community outside downtown, and you bring it home, this is where your children live. You live with your children in the same house. There's ventilation is poor. There's no good airflow. That can also cause your children and even yourself and your family getting tuberculosis.
Okay. Okay, yes, Dr. Sophia.
Yes, why do we have the big numbers of TB? There's a lot of stigma that is associated with TB. So, like I said, one person can infect over 10 people with TB in a year. So, if you have TB and you don't come out quickly to get diagnosed, you perpetuate the spread of the disease in the community. And we see TB more common in spaces that are more crowded, like in a prison setting, in a, like you said, urban setting where the population is high. In a school setting, if you get a child or a teacher with TB, you will see many more cases. So whereas compared to other diseases, this TB, you don't look for it. It finds you where you are, anywhere. So TB anywhere is TB everywhere. Yes, so it ends up becoming widespread when we do not find and treat it early. So the message to reduce that burden is really to get those with disease and start them early on treatment.
What about the fact that some people, you know, there is a tendency by the way these days of self-medication has become the way to go, especially, you know, like in the kind of settings we're in, where somebody will get a cough and just assume it's just any normal cold, and before you know it, they get drugs off the counter and treat themselves, and possibly might get better, but in that process might pass on. It could have been TB and they could pass it on to somebody else. What's your take on the matter?
Thank you, Sophie. Definitely, like you have stated it, that is a common practice. You feel unwell, you want to go out to the nearest drug shop or pharmacy, pick something so that you cool down either fever or cough. Now, TB presents with a cough most of the time because it affects mainly the lungs. But this cough is not a severe cough. So someone will not immediately think of going to the health facility to seek for care for it. They may actually go to the clinic, get something. The fever comes today, maybe tomorrow you don't get it. You just remain unwell a bit, but you can still do some things, routine things. So it makes you not to come out very quickly to seek for care. But we say that if you have this cough that is not going away for at least 2 weeks, you need to get worried and seek for health professional assessment. So you need to visit the health facility. If you have fever for 2 weeks and more, you need to do the same. If you lose weight unintended, you are not on a program for weight loss, but you are losing weight, you don't have appetite to eat food anymore, you need to seek for medical attention and they assess you. If you have chest pain, you need to seek for medical attention. If you have a child who is not growing well also, you need to seek for medical attention. So it is important that we stop somewhere with the self-medication. If possible, we discourage that. There are some practices that put us at risk of deteriorating in terms of our health that we need to do away with and seek for medical professional advice.
Now, Dr. Raymond,
in addition, just quickly to say, so the National TB and Leprosy Program in the Ministry of Health has realized that actually people do go and visit the drug shops. And we have developed a strategy to be able to reach out to now these drug shops in terms of the public-private partnership that we've gone into. We have started building the capacity of the health workers in these drug shops and let them know that, yes, people are going to come here and ask for Septrin and go for 5 days and come back and ask for Amoxil and go for 5 days until a year passes, they are having this cough. But remember that as they cough and they come for these drugs, they are even passing on the germ to you, tuberculosis germ to you. And therefore, we have now started building capacity of these private clinics, drug shops, to be able to start also screening. So the first time you come, you say you have cough, there's a tool that is available, and we're able to screen you And if you do not have any of those signs and symptoms, then you can take Herceptin. And if the cough persists, the same person where you go to, because naturally people will tend to go to where they can, where people will talk to them very well. You know, you'll be fine and this and that. So when we are in touch with these drug shops, private clinics where people go to, and we are trying now to encourage them to screen all these patients with cough. And anyone who has signs and symptoms is either given a container, take his sputum and take it to one of the labs for checking, or request the patient, please visit a bigger facility so that you can access TB services.
Now, based on the symptoms and signs and symptoms that Dr. Stevia said, there is a lot of similarity with COVID-19.
Yeah.
And now, of course, we know people have that alarm bell. The costs for a test of COVID-19 might not be what somebody can afford, vis-a-vis possibly the cost for the TB drug. How are we managing this, and how are we being able to really ensure that we are able to properly confirm that this is TB and this is not COVID-19?
Thank you once again, Sophie. With the TB, like I explained, the cough and the fever tend to take some few days in you, whereas with COVID, it is an acute illness. Usually within a few days of exposure, you start exhibiting if you cough, you lose your taste, fever, within a few days of exposure for something that you've not had before. But with the TB, it may take a little longer for you with these symptoms. But that doesn't mean that you cannot get COVID when you had your old symptoms of TB. It is possible that you can have an undiagnosed TB and you get also infected with COVID. The bad thing is that that puts you at risk of developing severe COVID, because you have lungs that are already affected and damaged by the TB disease. And then now you add on another very severe germ that also destroys the lungs. So you are more likely to get the severe form of COVID. So in this era also of COVID, we need to come out very, very quickly if we have any cough, so that we know what cough we have at the health facilities. The health workers will be able to assess you and do the test for TB, and also try to find out if the signs and symptoms you have could be related to COVID. Yes.
Okay. Then we get into the stage of the testing and the diagnosis. There are certain times there are those moments we don't want. Like I told you, very comfortable with our self-medication, drugs off the counter. How are we progressing in that area, especially in some areas where there are a little bit of limitations of some of the kits or the tools that you need to do the proper diagnosis?
Yeah, thank you very much for that question, Sophie. As a national TB program in the Ministry of Health, we've gone way far in terms of the diagnostic processes for tuberculosis. What's very critical is that we do first screen. And once we screen and you have those signs and symptoms, then we label you as a possible or a presumptive, or you are presumed to have TB. Not necessarily that you have TB. Now that big number now becomes slightly bit smaller, and we do think about 10% to 20% or 30% of those people that do come and have, are coughing or have a fever or have what, about 30% of them will be presumed to most probably have TB. Not necessarily that they have TB. Now that's the number we now subject to the lab investigation. And as a country, everywhere that we have a microscope, what we call our diagnostic and treatment units, all the public facilities from level health center 3 onwards up to national referral hospital can diagnose TB. And that's one good huge step. But when we've been using microscopes for time immemorial, it's still our strongest tool, especially in follow-up of patients with TB. But through government of Uganda, through partners, we were able now to have a more faster, a tool that we could use, which we call the Gene Expert. You've had His Excellency during COVID mentioned about the Gene Expert.
Yes.
And TB happens to have been the first one to have introduced the Gene Expert in Uganda. And this Gene Expert, as we speak today, we have more than 260, 270, 80 Gene Expert machines in this country. All our national referral hospitals, regional referral hospitals, a number of district hospitals, a number of health center 4s, and a few health center 3s have this Gene Expert machine. The Gene Expert helps in one or two ways. One, it is a fast diagnostic tool. So moment you have your sputum available, within an hour or so, you should have results. But two, it goes further to be able to discern what we call the simple or the drug susceptible that can be treated with the normal drugs that we have, and it can discern that TB from the one we call the multi-drug resistant or the rifampicin resistant TB. That's the drug that we use for our normal TB. But in a number of our patients now, we are beginning to see resistance to that one drug or two drug, rifampicin and isoniazid. So that machine can actually go a step further to tell you that no, you do not only have TB, but you have the resistant TB. And so we are killing two birds with one stone. And we have about, as we have said, we have about 280 machines around this country. And that's a start, and that's a very good start so far.
Yes.
So our diagnostic backbone is that good. Now in the facilities where it is not, we have worked with partners and government to make sure that at least the samples are picked from that lower level facility to where the Gene Expert is. And I think that is now taking root as we mobilize more resources to get more of these Gene Expert machines around.
Okay.
But Dr. Sophia,
All right.
Yeah, just to mention that the main test for TB is by looking at the sputum. So you give a sputum and it is looked at in the lab using the two main equipment he has talked about, the microscope or the Gene Expert machine. But the most available one is the microscope. And we encourage that all people who have provided sputum at health center 3s, the sputum is examined with the microscope so that we can provide immediate treatment for the number of people that the microscope can pick. But also refer, using the hub system, a sample to the 280 machines that have more capacity to pick even more TB from the sputum. We also have other screening tools that help us to aid diagnosis. The use of X-ray is something that helps us. We look at the chest and see the lungs, and the clinicians can be able to tell that the picture of these lungs could be related to damage by TB. And they go ahead and do other tests, either requesting for a sputum, or if it's not there, use their clinical judgment to make a diagnosis of TB. Yes. So we also use the the X-ray equipment. We also have introduced another test where we use it only in those people that are having HIV. When we want to identify or detect TB in this category of people, there's a test that we use on the urine for these patients. This helps us to detect this TB in this group of patients when they are very ill, or when their CD4s have become so low at about 200 cells. And then we can tell, the urine test can tell you that there is TB in in this person or no TB. And then you go further, do evaluation as a clinician and make a decision to treat the patient depending on how they present. If they can give you other samples, because the gene expert tells us whether the patient's TB is resistant, like he has said, or susceptible. So we would still need that test to help us understand the category of TB the person has, even when we have detected it in the urine and so on.
Now, in line, you've talked about partnerships you intend to have to spread a little further. What about where some patients or some people are comfortable going to their private hospitals? Now, when they go to the private clinics, actually not even hospitals, but clinics, most of these clinics have mundane routine tests. Based on the way somebody goes feeling, they'll check for malaria, for typhoid, for infection. I think that's the category in which they majorly focus. You'll find that TB is not one of those categories or any of the other bits that they'll give that much attention. What is the plan to do about it? Isn't it something you need to emphasize for them to have on their category list of, depending on the clinical symptoms of the patient? Yes.
So like you rightly said at the beginning, the burden of TB is high in this country, and we are on the road to really end this disease by 2030. And as a ministry, we have realized that we cannot achieve that without bringing on board the private sector. So we have planned to engage the private sector as one of the key steps in addressing the TB burden in the country. We are hoping that will build their capacity in terms of improving their acumen to suspect people that are coming to their facilities and offering the TB test for those that qualify or are presumed to have the disease. Now, the testing, they may not have it there and then at that small clinic, but they can pick a sample from you and route it through the hub system that I've talked about. We link them to the public facilities near them, and you still get the test done for TB. So every clinic, every private hospital should be able to screen the people that attend the clinic to see that they are not presumed to have TB, or if they are, they should be able to have capacity to take off a sample and link it for testing in the system. And the service may have a charge because of that arrangement, but the TB testing is free.
In the public health facilities?
In the public health facilities, yes.
Now, Dr. Raymond, that brings me to the question of the treatment. Because it looks like now we have specific and clear levels of the disease.
Yes.
There is a particular strain of TB and then another, then you also have the drug-resistant one. The drug-resistant one, I would assume, is like I have tested and been on a sample of the drugs, then maybe didn't adhere to treatment, so I get a resistant strain. So kindly take us through the treatment.
So the treatment for TB, one very critical good thing about tuberculosis is curable.
Yes.
Meaning that you get it today, once you start treatment, the available treatment that we have, you will be cured. 100% clean, no TB. And you will always, at the end of treatment, go for checkup and you don't have tuberculosis. But the treatment is readily available, as Dr. Stavia said, in all in the public health facilities. At least up to Center 3, you should be able to get that treatment. Treatment is using a combination of medicines. It's not one drug, but it's a combination of medicines. And those medicines used, first of all, you will take a combination of about 4 medicines for the first 2 months. And then you reduce that medication to about 2-3 medicines for the next 4 months. Meaning that you need to take your medication for a minimum 6 months. Minimum 6 months. There are those with some of the severe TB, like TB meningitis, TB of the bones, that will need you to take an extra maybe 3 months of treatment. But all the treatment is available. And this is now for the simple, what I would call the simple, but also has killed many people. The drug susceptible tuberculosis, meaning it is susceptible. It means that it is possible that the drugs we have can manage that particular bacteria or the particular germ that we're talking about. And the 4 medicines that we have, as I said, are in a combination form. We have what we call rifampicin. That is the most strong drug that we have, followed by isoniazid, which we also use, by the way, among patients that people that are normal but don't have even tuberculosis, but prevent them, especially the prisoners and those, the diabetic, those that we potentially can get the disease. So we prevent TB from them by using isoniazid. Then we have, I said rifampicin, isoniazid. We have pyrazinamide, and we have ethambutol. So, and all those are antibiotics. You can get them in a combination, and those are the ones you take for the first 2 months. It's very critical that as you take this treatment, have someone to look at you and support you. Because it is one thing saying I'll take these drugs, especially if you are coming from the background of being weak, having fevers all the time, vomiting and that kind of thing. So it is very important that you get a support person to help you. And after the 2 months, come back to the facility. So you'll be coming almost every 2 weeks until 2 months. Then at 2 months, we take off the sputum again and check it under the microscope. How are you faring? And if you are faring well, the germ is now not there, but you're still sick. So you need to complete the remaining 4 months. That's now when we put you on two rifampicin and isoniazid for the next 4 months. And you take it diligently, because remember, 4 months is also not a simple time, and you are taking these drugs every day. And one of the reasons why we are saying please make sure you swallow your drugs daily is because, as you've said, we are trying to avoid now the drug resistant, which is going to need more strong drugs and a longer time to take. The advantage now is that we have oral medicines for those the drug resistant TB, but still, if you cannot take for 6 months and now you get drug resistant TB, you're going to have to take it for another 9 months, 9 to 11 months, which is a much more longer time. So we encourage and advise and make sure we tell our patients that we are going to start this treatment. You have tuberculosis, you're going to start this treatment. It's going to be for 6 months. Prepare yourself for 6 months. But you'll need to come regularly, every 2 weeks, every month, for checkup. And even when you feel better, don't stop until the 6th month, when the health worker comes and gives you a good certificate of good health and say, now you don't have TB, you can, there's no more drugs, there are no more drugs to take, you can go home. So that is what it means to have tuberculosis. But the good news I want to tell our listeners and viewers out there is that TB is curable. Medicines are available in this country, free of charge, thanks to the government of Uganda to make them available and our partners. And we want people to make sure that when they begin taking them, take them diligently and complete your treatment. And once you've successfully completed treatment, you will live a normal, healthy, beautiful life.
We're talking about a normal, healthy, beautiful life. What are the chances that a person cannot contract TB again after having been on the treatment and successfully being cleared off? Because given the fact that it is airborne, are there chances that a person can contract it again?
Okay. Thank you once again, Sophie. Yes, the chances are there that you can actually get TB again. But we see very few of those. Once you have taken your treatment and it has worked and you've been declared cured, you are free of TB. But in some few cases, you may get some reinfection, because you are still in a community where there is exposure. We have scenarios where the person who is giving you TB is actually not yet found. You are staying with them somewhere, so you continue getting exposed. Yes, sometimes those scenarios happen. Or you get into a situation where your exposure is increased. For example, maybe you go into prison, or you become malnourished for one reason or the other. Then your chances of getting TB again become high.
Okay. Then what is the treatment for the children who have TB? I presume, do they also go for the 6 months? Is it also the regimen of a combination of the 4 drugs? How different is it? Because certain times you just even imagine it for the adult and you're like, hey, then you think about the child. Yes. What is it like for the children?
So for like Raymond said, we use combination therapy. But the good thing is that for sensitive TB, these drugs are put in one single tablet. The 4 drugs he talked about come in one single tablet.
Okay.
So you may take more than one tablet depending on the weight and the assessment the health workers have determined that your dose will reach when you take 2 tablets or 3 or 4. So you don't take the different drugs he was describing in separate tablets.
Okay.
That is the good news with the first line or sensitive TB treatment. And this is the same treatment that the children also use for their TB, except that one of their drugs is not in that combination. The parents have to dissolve the tablet, one of the components of that drug, in a liquid and give the child to drink. This was first of all to potentiate the effectiveness of the treatment. Initially, we used to use 3 drugs for this category of people, but it was thought necessary that they add ethambutol, the 4th drug that he was talking about. So this one is still in a separate form of a tablet. The parents have to make a solution and administer it alongside the other tablets also, which are also dispersible.
Now, in terms of
and the duration is the same.
Okay, the duration is also the same for the children.
Yeah.
Yes.
Oh, wow.
But
6 months.
I'll tell you, you know, children are a very interesting category of young people. When a child is sick, he's sick. When a child gets better, we will see all the signs and symptoms: smiling, walking, putting on weight. And these children, we've seen children that have come malnourished, can't sit, can't talk, can't even remove a fly off their face. But then at the end of the day, with the treatment that we're giving them, you really see a lot of progress that is made. And these children in 6 months, up and running. Where a mother has lost hope, a mother gains all the smiles and hope. And this is what actually shows that the medications that we're giving these children, interesting enough, they are disposable. They can dissolve. They are dissolved into water, and they have that very good taste. They have a very good smell. So really, the children, we feel for the children. But at the end of the day, I think at least we see a lot of good success stories when we see children getting better from tuberculosis.
Now, what I find quite impressive is that the drugs are available at no cost. But given that they are available at no cost, why is it, you know, I understand the infection rate, how we are overpopulated in particular communities, but why is it that, you know, I still don't get it, that it is getting worse? Yet with the drugs being available, you would expect us to be getting there slowly, by actually be a lot better. You get it, as opposed to now HIV, where they have scenarios and the drugs are not that cheap to get by, and for them it is getting suppressed. TB is getting up there.
Like we have said from the beginning, the good news is that when you get the TB, it is curable.
Yeah.
So we don't add on to onto the cases at the end of 1 year, unless of those that we don't identify. the drugs are free, but the issue is we are not reaching out to everybody with the disease every year. So we keep getting additional people spreading the disease. If we are able to get all the about 90 people that develop TB in a year, put them on treatment, we would see the picture getting different and different over the years. And that's where we are planning, we have planned that we should go, at least reach over 90% of Ugandans that develop the disease annually, and keep them on treatment to over 90% magnitude completing this treatment. That way we should be able to see the disease coming down. But also we are promoting prevention now, which was not before. We target people who are likely to develop from that silent form of TB to the active TB disease. Give them prevention, and then their chances of developing TB are reduced. So those combined should be able to help us reduce the burden of disease in the next 5 years that we started last year. So we should be able to see some better statistics going forward.
Sophia, I just wanted to add one thing, and pertinent question, and Dr. Stavia, thank you for that answer. And this is just an appeal. TB affects more men than women. That's a statistic we can have a whole day's discussion. And you all know, women, we have that poor health-seeking behavior. And as a result of that, we have gone further as a Ministry of Health to make sure we reach out now to the men in their comfort zones, in their drinking places, in their places of work, in their places, wherever we can get these men, to make sure that we reach out to them, talk to them. There's a lot of stigma, as Dr. Stavia said, there's a lot of stigma out there. People still have this notion that people are bewitched when they get tuberculosis. They are bewitched. My neighbor is bewitching me because I have a house. In actual sense, that house you are mentioning does not have ventilation. And you're getting TB as a result of that. Or because you've just got some bit of money, you think that now you can go into a Marwa group and you find yourself coughing and you're sharing, and you end up finding that as you sit together around there and you're coughing, you are really transmitting, or someone is transmitting to you. And you have this pompous of saying, but I mean, this is a normal cough. Children at home who get cough, those ones can get treatment. Me, I will go through this. And at the end of the day, you find that these are the men that are not seeking treatment, they are not seeking care, they are not even probably maybe even listening to us on TV because they are in their comfort zone somewhere. So we appeal to the population out there that whereas we know stigma is real, but we again want to say, if you have a cough, if you have developed fever, and you are getting treatment and you are not getting better, seek advice, seek better services, and you should be able to get the services. And once you are coughing, get out, treat you, and you will not be able to spread it to your loved ones at home or the people in the community. And in so doing, if we are able to reach 90%, as Dr. Stavia, plus of all the people that have TB in this community, we shall start seeing numbers going down. And that's what our target is.
Okay. Now we get to the World TB and Leprosy Day, where it's going to be commemorated on 24th. And I'm meant to understand it's in Moroto. Why Moroto of all places?
Thank you once again, Sophie. We shall commemorate World TB Day on the 24th of March, joining the rest of the world. Usually the purpose of this commemoration is to raise awareness. And it's good that we are here this evening, and I'm hoping that our listeners will pick something about tuberculosis today and get out there and seek for services. So why we choose to commemorate the day in Moroto? Moroto is one of the far, if I may, parts of the country, and you find that it's not always easy for such days to get to their level, yet they are also part of the country. So we are reaching out to them this time around. But also, as a region, we see more disease burden in the population of that region. Whereas we have a prevalence at around 200, the one in Moroto is in 2,000 per 100,000 population. So you tend to see more and more active cases coming up, including among children, because there is transmission that is happening. There are people with TB in the community that have not yet been diagnosed. So this kind of commemoration makes even the service more accessible to the community. They create awareness to the people in the region, and we hope that way we can identify many more people into the pool, thus halting the chain of transmission of disease. The other key issue that we looked at to take the day to Moroto is that whereas there are many cases and they keep coming into the system, their ability to complete the treatment of 6 months is so wanting. Their treatment success has been the lowest in the whole country for a very good period of time. Although now with the persistent engagement with the different districts, we see it improving. So those are some of the key issues that are taking us to Moroto to further create awareness about the disease among the people in Karamoja, but also to use the opportunity to identify additional cases. Right now, the districts are working hard to do community sensitization and community screening to see that they get TB diagnosed and started on treatment. The theme that we are having this year is related to the challenges that are also in the region, especially the slogan, "It's time to end TB, support every person with TB to complete their treatment." Because that region actually was not, the people with TB were not completing the treatment. So we focused on that, and the reason we are commemorating in Moroto.
In terms of them not completing their treatment, has that got to do with the nature of work? Because, you know, they are nomadic nature and they are always on the move? Possibly?
Definitely. That is one of the contributing factors, but also there are other factors. The families in Moroto tend to be food insecure, and the treatment, we didn't go into the details of the side effects. Is that we've had over 4 drugs. They are strong, they need a body that is well nourished. So some of those also contribute to them not being able to complete treatment. The other issue that we identified was the distance they have to move. Somehow the facilities in the region are not very easily reached. That we have worked around it and tried to create even what we call community drug distribution points, but also putting the treatment at health center 2 level to ease on the movement for the people. Engaging the leaders of the teams that look after the cattle when they are going to move, to liaise with the health facilities to make sure that they move with the treatment. So we are trying all ways to make sure that the people access their treatment and still continue to do their routine work.
Okay. We just have a few minutes to the top of the hour. I'd like to beg at this particular point for each one of you to share with me your winding up remarks. I'll start with Dr. Raymond. What's your final comment to a person who's watching you right now in line with TB?
Thank you very much, Sophia, and thank you, UPC. To our listeners, I'm a man. And as I have said, TB affects and infects more of the men by the statistics that we have. more men are having TB compared to women. And I'm appealing to our men, fellow men, TB is out there. TB is curable. Don't be a man and stay at home. If you are coughing, if your family members are coughing, you are a man when you go to the facility and go with your family and get them, all of them, tested, diagnosed, and if they have TB, together as a family, you can take treatment. TB is curable. And this is my appeal to men. Let's go out, let's seek TB services, let's be screened, let's be tested, and let's be men and have our children and our family members get treatment when they have TB. Okay. Thank you very much.
Okay. Dr. Sophia, your winding up remark?
Thank you once again, Sophie, and thank you to our listeners. I would like to call upon all Ugandans to come out of wherever you are when you have a cough to understand what this cough is about. It's by assessing your cough that will be able to rule out tuberculosis, but also be able to get all the TB that is happening out there. If you have a cough, you have a fever, don't just continue with your normal business without seeking medical services. I also call upon you to uptake of the prevention services that we have provided as Ministry of Health. If you are staying with someone with TB and they have assessed you and you are required to take medication to prevent you from developing TB, please take this treatment or give it to your children, especially the children whom you are staying with but have no active TB. The people living with HIV, if you have not taken your preventive therapy, demand for it when you go for your next visit, because you are at a higher risk for TB than the rest of the population. Seek for your preventive services. For those who are diagnosed with TB, take responsibility to finish the TB treatment. And for those that stay with people who have TB, support them to complete the treatment. There's a lot of support you can give them. You can remind them. You can provide transport for them to go back to the facility. You can provide the food they need. You can also administer the treatment. You can help to see whether they have developed any adverse event and report it immediately to the health workers. So let's support everyone with TB to complete treatment. If you are a health worker, wherever you work, do not finish that clinical assessment of the patient that is before you without knowing whether they may have one or two of the signs and symptoms of TB. People come with TB to the health facilities and go back with it because we are not keenly looking out for it. Let's not look at it as an additional burden. Every time you don't diagnose someone with TB and they keep coming to the health facility, they bring this germ with them and they put you at risk of getting TB as a health worker. Join the movement to identify and treat TB so that we can end TB by 2030.
Okay. Thank you so much, Dr. Sophia, and thank you so much, Dr. Raymond. I believe you have summed it up all very well for a person who's watching you right now. It's just a few minutes to the top of the hour. I'd like to beg you to keep watching UBC. For the 10 o'clock bulletin will be coming your way shortly with Lauren Kazimoto. Have a good night from me and the guests in studio.
Thank you.
Thank you. Good night to our viewers.
Brought to you by
Your Health Chart is brought to you by National Medical Stores, who are mandated to procure, store, distribute essential medicines and medical supplies to all public health facilities in the country.
Today tastes like a new tradition, like an old favorite. tastes like all hands on deck and all eyes on the prize. Today tastes like a piece of the action, and it never tasted this good.
It's better to foster respect instead of fear and pain.
Cause a good school equals a better life.
Raising voices.
Today tastes like a new tradition, like an old favorite. Tastes like all hands on deck and all eyes on the prize. Today tastes like a piece of the action, and it never tasted this good.
Up next on UBC, brought to you by
Keep the lights on. Use Airtel Money to pay for all your Yaka bills conveniently. Open the My Airtel app to buy Yaka units. Airtel Money. Simple, secure, borderless.
It's no secret that ICT makes learning easy.
The strides made in our field could not be possible without it.
And now we can watch our favorite show.
My radio is my best friend.
UCC provides an enabling regulatory environment and policy guidance for healthy competition. We also facilitate ease of doing business in the communications sector through licensing, standardization, spectrum management, tariff regulation, rural communication development, and consumer empowerment. An informed consumer is an empowered consumer. UCC supports local content and innovations. Driving the development of a robust communication sector in Uganda is Uganda Communications Commission.